Good evening, everyone. Welcome to the Retina SAP office webinar. Why do these meds not work for me? It is my privilege to introduce Claudette Medifant, Retina SA Head of Science and Director of Retina International. Also Karen Denton, Retina SA Head Office Advocacy and Education Officer, and Retina SAP Office Manager Gail Sillier. If you've ever asked yourself the question, why do these meds not work for me? This webinar is your opportunity to find out why. Because this afternoon, Karen will be answering all your questions regarding why medications are effective for some, but not for others. Let me tell you a little bit about Karen, who we are so privileged to have, who has joined Retina SA, and we're so privileged to have with the portfolio of Head of Advocacy and Education. Karen has studied all aspects of nursing. She has a degree in psychology and a 30-year plus career in diabetes education. She's lectured internationally and chaired various national and international diabetes education organizations. We are so glad to have her on board. Just a few house rules. If you have any questions, we will take them after the presentation. To ask questions, now I'm going to ask Claudette just to tell us what the shortcuts are that you can use for the questions. Claudette, can you hear me, Claudette?
You can use Q&A, the icon, but there's no shortcut. Or you can use chat, and the shortcut for chat is Alt-H. Or you can click on raise your hand icon, or you can use the shortcut Alt and Y, which is raise your hands. Whatever you use will be fine, and we will answer those questions at the end. So over to you, Karen.
Then just as a, sorry, Karen, I just would like to also say, if there are any questions that anybody has after the webinar, they can direct them to the Retina SA website, www.retinasa.org.za, or to the PE office at pe.office@retinasa.org.za. And then just to tell you that due to circumstances beyond our control, and despite nearly 2 months of contacting the officers to get accreditation, we have not managed to get the accreditation yet. So the minute we have it, we will let you know. And then we will also ask you to please complete the poll. When you get your thank you letter for attending from Zoom, the poll questions will be there for you to answer. And then without further ado, Karen, the floor is yours. We can't wait to hear what you have got to tell us.
Oh, thank you. And this afternoon is actually not a very heavy session because we're looking at the present, but we're also looking into the future. So let's have a look. As everybody knows, I am with Retina South Africa, where I do function in advocacy and education. And we're not a very big team, as you all know, but we are pretty effective. I also work very closely with the Low Vision Center of Learning. And I do have a disclaimer before I get started, and that is that this program is made possible thanks to an unconditional educational grant from Bayer South Africa. So we do owe you, Bayer, a huge thank you. What we're talking about today is pharmacogenomics. Now, this is a very big word. What do you think pharmacogenomics means? If we break the word down, it actually does explain itself. It is the science of personalizing your medication, your drug treatments, based on your own DNA profile. At the moment, what happens is if we have somebody and we give them a tablet, we know that for some people, that will be very effective. It will be fine. For some people, you'll need a double dose because it's only half effective. It doesn't work as well as for other people. For some people, it's doubly effective and it works hyper well. And for some people, it doesn't work at all. And I'll go into this again in a moment. Pharmacogenomics has taken the imagination not only of the medical and scientific world that we have here, but also the popular press, and even a lot of magazines like Time Magazine and others are talking consistently about this approach being the drugs of the future. DNA is going to be how we determine what medications you have. And you can look forward to your prescription looking like this. Your prescription at the moment, we know, has your name, your address, and then obviously everything about the medication. But in the future, it will also have your DNA profile added to that prescription. So, but why is this? If we look at us, are we really all the same? We look pretty much the same. We all have two eyes, a nose, a mouth. We look pretty similar. But if you look at this couple, for example, very clearly a business couple, and compare them with this family, you can see immediately that there are differences. But, well, we share a staggering 99.97% of our DNA. So when you look at these people in the top picture and in the second picture, they share 99.97% of identical DNA. So only 0.03% is different. That's very little. But that tiny amount, that 0.3%, determines hair color, texture, the waviness of your hair, skin color, texture, eye color, your size, how tall you are, your shape, if you're round, if you're tall and thin, and every single thing that makes you, you. In other words, everything that makes you unique is contained in that 0.03% of your DNA. So if we look at our genes, the genes then determine whether we are short and round or have an apple shape, or if we're tall and thin, if we are able to exercise and we are able to do all kinds of things like people do in the Olympics, or if we are simply couch potatoes. So then we have to ask ourselves the question then, based on this, why then do some people eat anything they want to? They can eat anything, while as other people can eat one donut and gain a whole kilo. Once some people have one tot and they're drunk, whereas other people seem to be able to drink an entire bottle and they're fine. Some people very seldom exercise and they seem to remain fit, while others exercise regularly but never seem to quite make it. And we can carry on. People sit in the sun, develop a tan. Others get a severe burn after just 10, 20 minutes. And we can carry on and on. There are just so many differences. But this leads us then to understand that why do medicines that work for others not work for me? If you react differently to coffee and food and everything else, then obviously you're going to react differently to medication. Very long ago, more than 100 or just on 120 years ago, Sir William Osler said that people are very different. No two bodies are alike. No two individuals react alike, and they don't behave alike under abnormal conditions, which we know as disease. So if we look at people with the same disease, taking the identical same medication, we know that some of them will have a full benefit with no side effects, no toxicity, no problems. Some will have toxicity, side effects, but no benefit. That medication is ineffective for that person. Some people have a full benefit with side effects. And then there are some who have no toxicity, no benefits. That medication doesn't react for them at all. So that means that when a doctor prescribes for you, he needs to know quite a lot, because otherwise this becomes quite a hit and miss affair. In other words, you have a 1 in 2025 chance of that medication working adequately, properly for you without the side effects. And once again, it is obviously because it is all in that 0.03% of our genes. If we look at this, we then can understand that the way our bodies handle that coffee, that alcohol, that food, exercise, everything means that the way we handle medications is going to differ for each and every one of us. So even aspirins, paracetamol, antibiotics, cholesterol-lowering agents, vitamins, diabetes medications, and we're going to look at eye medications as well. We know that everything affects each of us completely differently. There are no exceptions with any of the medications that we know at the moment. Our individual responses are just too completely different. In fact, interestingly enough, there are certain grocery stores that are now allowing people to shop with their DNA. In other words, when you go to certain stores, like in the UK, there are quite a few in the United States, but in the UK, there's Waitrose and John Lewis. If you shop there, you can go have a quick on-the-spot one-time cheek swab. That's all they do. They take a little swab from inside your cheek. They then do the test on site for you, and that will generate a personalized DNA report. Now, obviously, this is not a full DNA screening. It is only to do with the way your body is going to handle food. Then you can start using the DNA Nudge smartphone app, which is free of charge to download, or a wrist-worn DNA band that is showing in the picture here on the right. And when you get to any product, you simply scan that product using the app or the band, depending which you prefer. The DNA band will flash green if this product is appropriate for you, and it will be red if it isn't. But if it turns red, it will suggest a suitable alternative that would suit your specific DNA profile. So these grocery stores now are selling their foodstuffs based on people's individual DNA. The test at the store takes a few minutes, and then you shop accordingly. And the little pamphlet that they give out to people to explain it goes through all the steps that I have just explained to you now, so that people know that when they are shopping, the app will be able to tell them if that product is suitable for them based on their DNA. And because we know that DNA tends to be familial, we can assume that very often, if the mom is tested and she's doing the grocery shopping, it might just be fine for her children as well. But it's certainly better than the hit and miss that we do at the moment. We just buy and hope that it works. So it then makes sense that the medical profession should start prescribing medication based on our individual DNA profile. And a few already do so, but not too many. But in the future, our medications are going to look like this, with our DNA profile included. The future is approaching, but it's approaching pretty fast. Pharmacogenomics is a critical area for improving drug therapy and prescriptions in the very near future, hopefully. This new science also then challenges the widely held view amongst many people, including many professionals, that drugs are pretty much the same and will work the same for everyone. They don't. So now we already know that more than 50+ million DNA variations have been identified in people. There are thousands associated with specific diseases, including certain eye diseases. And there are thousands associated with certain drugs, very specifically. And the number is increasing with drugs that have labels that have that pharmacogenomic info included as well. And this is based on the association between the genes and the individual sensitivity to each and every drug. But this is going to be the way we are going in the future. And studies already show that medications are completely ineffective, a waste of money, a waste of time in 40% of patients who take routine medications for asthma, depression, and even for diabetes. This has nothing to do with the quality of the drug, let me say. The quality is perfect, it's fine. It is simply due to the fact that we are all completely genetically unique. So if we look, for example, at this genetic profile of people with diabetes, you can see that there are so many genes involved that is not surprising that a doctor might prescribe something for one person and something completely different for another, because clinically they would have noted that a person responds this way to something and that way to something else. And this is one of the reasons why we tell people never try to share medication with somebody else. And I get so many calls from people saying, but my neighbor takes so-and-so. Why doesn't my doctor give me that? Because it seems to work fine for them. Or your neighbor gets something and you just give them some of your medication. That's terrible. You can't do that. People are just too different, and you could be putting a person into danger with that. I'm going to say a word or two about anti-VEGF therapy. They have identified a certain gene that showed that if you have a certain one of the injections, you needed a much higher dose of that medication to control your macular degeneration. It is based on this specific gene, but I'm pretty sure that they are uncovering more and more and more genes so that they would be able to tell you exactly, if you have macular degeneration, which of the products is going to be best for you. And we will say a little bit more about that in a moment. We do know that somebody called Abedi et al. Found that a single gene could determine whether a person's response to anti-VEGF injections with macular degeneration would be successful or not. And as I said, this kind of research needs to continue so that we can be very specific in exactly how and what we can prescribe for each and every person. But the research is in its infancy at the moment, so don't go rushing to your nearest lab and saying, I need a test because I need anti-VEGF. At the moment, we have a different approach, which I'll go into twice. Now, unfortunately, patients' reaction then to anti-VEGF therapy can be unpredictable. The response to some of them, you could have side effects, and healthcare professionals are concerned because we cannot predict at the moment who and who may not be affected. So we have to just follow certain precautions. So if we look at the options that are available, our traditional way of doing this at the moment, and this works pretty well, is they will start you on one of the available injections. And if there is no response after about 3 months, you really should change to one of the other options that are available. And there are choices available to you. And I'm going to stress this again because it is so very important. In other words, genes and the way our genetic profile manifests in every single one of us is the basis of our lives and how we live our lives and how we will be taking our medications. I'm going to just say a word about tachyphylaxis because that is quite important. This is a medical term that describes a sudden decrease in your response to a drug, even after you've taken it for some time. You suddenly stop responding to it. It can occur after a single dose or after a whole series of doses. And if this occurs, the doctors normally stop and switch you to something else. But if there isn't something that is similar, they will simply then start you on a very much lower dose. For example, in the eyes, they will change you from the one product to another. And if that product doesn't work for you, you have a third choice. To be complete in this, we do need a full genetic profile on each and every person, which isn't available at the moment. And however, even if we look at the costs, we find that the data shows us that doing dosage based on pharmacogenomic outcomes eliminates costs associated with morbidity, ineffectiveness, reactions, and hospitalizations. And here I'm going to look at just one product. This is quite a large study that was done on the hospitalization rates for heart patients who were taking warfarin. And if they were able to get the genetic profile of those patients and then prescribe, increase or lower the dose based on their DNA, they reduced the hospitalization rate by 30%. That's a massive saving for those people, for everybody. So in summary then, if we look at this, if we look at the patient population, the standard approach is to take a risk and try treatment A, see if it's effective. If it isn't effective, then that treatment has gone to waste. We've wasted money on it, and we try treatment 2. And if that isn't effective, we try treatment 3 and 4, etc., etc. Genetic approach will give us the tailored ability to choose exactly what medication will work for you. So no wastage, no side effects, no complications, and that really is the scientific way to go about it in the future. Today, as we said, there are thousands of genetic tests available, and we know that about 10 new tests are being introduced every single day. And in the future, our scripts are going to look something like this, where a medication will be listed on the left. For example, halfway down, there's aspirin. And then on the right-hand side, it will say whether that is effective for your specific situation. And in this case, it says normal effectiveness to aspirin, etc. It will list every medication that you're on, and then on the right-hand side will say whether this is appropriate for you or not. In green means that you are fully able to take it. Orange means maybe investigate a little bit further. And red means stay away from it, because in this person's case, for example, they have a reaction to statins, and the risk of that adverse reaction means they should not take statins at all. That is how it's going to be in the future. So if we look again at macular degeneration, we know that early detection and intervention is essential. And today, for wet AMD, we do have, thank goodness, the injections. There are 3 available, plus 1 that is off-label. And as I said to you earlier, we normally start with the 1, and if that is not effective, we do have the other options available as well. Now, these are sight-saving products and are probably one of the most important medications in the armamentarium of a doctor today. In the future, however, a pharmacogenomic test will help to avoid adverse reactions, ineffectiveness, all of these problems that we've spoken about. It will also support physicians in working out the most appropriate treatment for you, for each and every complaint that you have. This will represent another element which will bring medicine from a reactive discipline, which we do now. We give you something to try and see if it works, and then, if necessary, we change it, to a preventive discipline where we can give you something in advance and know that it is going to work for you. Besides improving how the current drugs are being used, genomic research will lead also to the development of better and better drugs. And we can expect drugs that are highly effective without side effects. I'm going to say a little bit about, and this once again is very, very futuristic. We're going to talk about subretinal gene therapy and the future of macular degeneration therapy. There is a product being researched called AVA101 that increases the action of our anti-VEGF injections. So if you have a subretinal injection of AVA101, after 6 to 8 weeks, you have a second treatment and then just one anti-VEGF medication. And after that, you only ever again need anti-VEGF if and when needed. And in the trial, they found that they used an adeno-associated virus, which is a tiny, non-harmful virus, and injected 100 microliters of AVA101, which is a tiny, tiny dose under the retina. And at 12 months, they found that patients had gained between 9 to 12 letters on the eye chart. So this was really, really positive research, and it's something that we can probably look forward to in the next 5 to 10 years. The future is not too far away. It is almost here because newer, more specific drugs designed for you, specifically for you, are becoming available regularly. And we know that new delivery systems are already available where nanoparticles can be delivered, for example, into the eye. And 20th century medication then is already history. And with that, I'm going to hand over to any questions that we have. And just to remind people, before we start the questions, that we need every family with a retinal condition to please register with Retina South Africa on retinasa.org.za. Thank you.
Thank you, Karen. That was absolutely amazing. And I'm sure that judging by the reactions we've had on the chat shows that Manny said, wow, shopping based on DNA sounds amazing. Now, I know there is a place in Johannesburg where you can get a DNA profile based on what you should eat. Perhaps you'd like to just spend 2 minutes talking about that?
There are a couple of labs, they're private labs, so you do pay. I believe that there's one at the Thrupp Center in Hyde Park who are able to do that profile for you. They actually do quite a full profile, and they regularly, I spoke to them not long ago, and they said that they regularly add more and more medications. They work very closely with a lot of the doctors in and around Johannesburg. And according to your profile, they're already able to tell you what foods would work well for you and what wouldn't. Obviously, you wouldn't be able to possibly scan these, or maybe you can if you download the app. But they are also able to tell you quite a lot of medications already. So, but I believe there are quite a few of them.
That's great. And Altus says, this is so amazing. And somebody said, I'm not sure if it's Altus. So if, for instance, you have high blood pressure, will this show up on pharmacogenomic outcomes?
I'm not sure if they have the actual tests available yet, because something like high blood pressure is so multifactorial, and the causes, they're just so many. anything from cholesterol to what you've eaten to your stress, an infection, diabetes, all of these things, and dozens of others cause hypertension. So I'm pretty sure that this is going to be quite a broad outlook. And what they're going to have to do is first diagnose your condition. And if that condition is associated with hypertension, work through it that way. But they would be able to, in the future, see how you would respond to the different antihypertensive medications.
That makes sense.
Okay, and then there's a question from Lazarus Mutimba, who says that when will the future arrive? There is currently a worldwide COVID-19 vaccination drive on which we are all given a one size with the hope that it will fit all of us. In fact, this is happening with pretty everything else in our lives. We are a family of 6, meaning that when we buy food and cook, we need six different menus according to each one of our DNAs. Imagine how expensive this will be. What about the ongoing researchers? A researcher cannot possibly come up with answers for all our genes, meaning that we are wasting a lot of money on research.
No, I don't think it's a waste of money, because I think in the end it's going to save a lot of money because of all the wastage of medication. But just to get back to your food choices, if you're a family of 6, you probably have a very similar genetic profile between all of you, because the genes are inherited from your parents. So whatever the parents have, the kids are going to most probably have as well. And so we're pretty sure, Claudette knows more about this. She's the research genetic lady. Pretty sure Lazarus on this point, Claudette.
Well, I think, we call this really personalized medicine. And I think the fact that we're going to have our choice of foodstuffs in future reliant on our DNA profile. But I think in the meantime, if we can use our common sense very reliably, for example, if you have obesity in your family, which we know is one of the most significant effect on if you're going to have diabetes or not, as a family, you can all eat more healthy, you can practice healthy eating choices, and you can certainly increase your exercise. And I mean, we know there is diabetes, there's obesity in families. You see the families walking down the road in the supermarket, and you have an obese mother and obese father, and you have obese children, even down to really small children. So obviously there is something going on in the family that is affecting all of them. And now without even a DNA profile in sight, without even a doctor in sight, anybody with any common sense will look at that family and say, what are their food choices? What are their lifestyle choices? And we know that unless they change their lifestyle choices, somebody or all of them are going to end up pre-diabetic or diabetic, and with all the resultant vision loss and limb loss and cardiovascular and all those internal problems combined. So we can use our common sense without having a DNA profile.
Exactly. Thank you, Claudette. And then also, just to address Lazarus's point about the COVID vaccine, remember that the COVID vaccine is not a treatment. So it's not a treatment that's going to work for this person, not another person. It is a vaccination. In other words, it is a protection that they're giving you that is going into your body to go and fight. Just like, we got smallpox vaccines, and the smallpox vaccine protected us from getting smallpox. And then we got the BCG that protected us from TB. Then we got measles vaccines to protect us from measles. So a vaccine is not a treatment, and it works somewhat differently or very differently. But so that's a very good question. Thank you.
Yeah. And Nolene says, thanks for the talk. It is of value that most of these are complex disorders, including metabolism of meds, and the key being complex.
Yeah.
Need to be cautious not to assume one genetic variant to create a profile.
Exactly.
What Claudette has said is extremely valid. we know enough by standing on a scale and looking at family history. Thanks.
Exactly.
But maybe you'd like to talk to people about your string test, because I think that is so low tech and it's so important. Please tell people about your string test.
Oh, my test for diabetes.
Yes.
You take a piece of string and you put it around your waist, and then you measure around your hips. And now people never know where the hips are. It is where your femur or your upper leg joins onto the rest of your body. In other words, exactly where your leg bends from the hips. So you measure the waist and then you measure the hips over that area. And if your waist is larger than the hips, you need to start being really careful, because it is a warning sign that you are possibly getting into trouble with problems like cardiovascular problems, diabetes, and you need to do something about it pretty quickly. Also remembering that exercise is very, very important, and without exercise, insulin cannot function at all. But also correct eating. Now, I'm not saying that we all have to go onto this or that diet, but what I am saying is that the current approach that we have to our brown and white diet is not the healthiest way to go. And it can certainly predispose us to all kinds of problems. So including as many colors into your diet as we can is very, very important. But I also want to ask Claudette, there is one other product that people like to share for eyes. And I know that this is quite a hobby horse of yours as well, if you'd like to comment on that.
Absolutely. And this is kind of taking your idea about your genetic profile. For example, we have a condition called Stargardt's or Cohen-Rod dystrophy that affects young people, causing central vision loss. And it occurs most often in families with no previous history of blindness, because it's a recessively inherited disease. And Nolene is on the line, and if anybody wants to consult Nolene, she's a brilliant genetic counselor, and she will tell you all about the genetics. But this gene that is one of the major genes causing Stargardt's or Cohen-Rod dystrophy is called the ABCA4 gene. And with this gene, this gene mutation, if you have this gene mutation, your body, your retina cannot metabolize vitamin A. So if you take any supplement containing the vitamin A, it will just build up the toxic form of vitamin A in the retina, and you will increase the rate of your degeneration. Now, having said that, we know, researchers agree that there is an oxidative stress pathway that is common to most forms of retinal degeneration. And a number of years ago, a very effective antioxidant and mineral complex was actually devised and tested. Again, the favorite clinical trials, which we all know about now, was tested on people with dry age-related macular degeneration. Now, because it is an antioxidant that affects people with age-related macular degeneration, a lot of people falsely assume that it's fine also for people with Stargardt disease. Well, in the beginning, that was disastrous because the early form of Ocuvite actually contained beta-carotene and vitamin A, but now they have taken that out. But still, it was never tested or formulated for people with Stargardt disease. So we appeal to people, if a medication or a supplement has not been proven to be safe for your specific eye condition, and that includes all sorts of health products. We get people requesting daily, is ginkgo biloba beneficial or saffron? We don't know. Unless it's being treated for your specific eye condition, consider that it is not safe. So that's just a warning. There is a very effective antioxidant called Retina Plus that contains lutein, zeaxanthin, alpha-lipoic acid, and L-glutathione that is very good. It's been shown to slow the rate of degeneration in retinitis pigmentosa, in cone rod dystrophy, and in Stargardt disease. But if you feel you can't take that, you don't want to take it, then the alternative is looking at your diet. Lots of leafy green vegetables with lots of red and not too much yellow vegetables. So be careful. And for people with Stargardts, not only is it in supplements, there's a green light system. Green vegetables is go. You can have as many of them as you like. Orange vegetables or yellow vegetables, like carrots, you can eat carrots. And you need beta carotene for other systems in your body. But caution, don't drink carrot juice every day. And then red. So the red is the meat that contains from liver that contains vitamin A directly. So it's either calf liver, veal liver, ox liver, even chicken liver. So avoid those red foods. And if you follow that, you probably won't even need to take a supplement, and you will be helping to slow the rate of degeneration in these conditions. That's done.
Thank you. That's very important, because a lot of people are not aware of that and just continue on their pathways.
So we've got another comment. Thank you, Corin. Going to do just that string test. So at least we've got someone going to do the string test. And you know, and of course the thing is that we know from COVID, and maybe you'd like to comment on that. We know that post-COVID, 15% of people are now being diagnosed with diabetes. Were they pre-diabetic or not? We don't know, but perhaps you'd like to just expand on that a little bit.
Well, you see, if the pancreas is under stress with a person who is so-called pre-diabetic, the stress of the infection, or the stress of any infection, in fact, would put such a burden on the pancreas that it could no longer cope, and the person then develops latent diabetes. But some of the people who are developing diabetes after COVID are also developing type 1 diabetes, which means that it could be, we don't know because they still have to do the research, that the virus is attacking the little beta cells in the pancreas, just like the Coxsackie virus has always done, and is one of the major culprits, in fact, for causing type 1 diabetes. But if COVID is also a culprit, then it is a problem. But one thing I do know is that I have received dozens of calls from people who have either recently been diagnosed after episode of COVID, or who have diabetes and their diabetes has gone completely out of control after developing COVID. So luckily we're able to address both situations. So just be careful.
Would you tell us, what are you advising those patients to do then? They know about insulin, they are controlling it, but how can they improve their control of their diabetes and their lives?
Okay, the most important thing, and the temptation is, if a person presents with a sugar of 30 or 35, 40, the temptation is to give a huge dose of insulin and whack that blood sugar down as quickly as possible. Now, that's a problem, because any drop in blood sugar is registered in the body as an emergency, and the body then reacts with all kinds of things. It will destroy available insulin, it'll put glucose out of the liver, it'll do everything in its power to get that blood sugar back up again, because it doesn't look at the starting and end point of a sugar drop. It just registers that the sugar is dropping. So if it starts from 30 and it goes down to 15, the body will react in the same way as if you're having a hypo and the sugar started at 8 and it's gone down to 2 and you really need help. So the treatment then, and the approach for this, is in fact then to take very small doses regularly, bring that sugar down very gradually, and as soon as you have your baseline, you'll probably find that it is fine again.
And what about exercise in those cases?
Exercise is very, very important. Now, as we said earlier, insulin cannot function without exercise. And the more you exercise, the better the insulin is going to function. Now, unfortunately, with something like COVID, we do know that sometimes there are comorbidities, and you just need to check with your doctor that you don't have an effect on the heart or effect on the lungs or something like that. That could, but that would be fairly rare, I hope. But a small amount of exercise, start introducing exercise little by little, just to get that blood sugar down, just to get that insulin working properly on your behalf. Because coming out of COVID and then running off to the gym is not going to work for everybody. It could, in fact, be dangerous. So always start these things slowly and then build up.
That's great advice, Corinne. Thank you. And we hope that people actually appreciate that and realize that, in fact, we have control to a certain extent, in fact, to a large extent, over our health and over what we do take. And what can you say to the anti-vaxxers? Because we know they're out there.
Well, you know, everyone's entitled to their opinion, but you have to use your intelligence and decide, who are you going to believe? The scientists who have spent a lifetime in this kind of world and this kind of research and looking at what is best for everybody, the best treatment, the best prevention, the best everything, the best vaccination? Or are you going to believe that little bit of nonsense that you have just read on your mobile phone that says, beware because they are planting chips into you, whatever? Well, let me tell you, if they implanted a chip when I had my first injection to see where I am, they're welcome. They're welcome to know exactly where I am 24 hours a day, because they can see where I am on my phone anyway. Secondly, if they have put in something to change my DNA on this arm and I'm about to sprout green horns or blue ears or whatever, then fine, carry on. I'm happy with that. I'm always happy with any advance. So if I turn into an alien overnight, it's because I've had both injections.
And I think it's very important. A lot of people ask, what is the effect of the COVID vaccination on your vision?
That is quite a complex question again, because stress, we know, has a massive effect on the blood vessels in the body, especially those tiny little blood vessels going to the eye. So all the stress related to COVID, the stress related to isolation, being locked away, and then the lack of exercise, so the blood isn't flowing adequately through the body. There are so many factors that do put us at a higher risk for damage in the eyes. And if we have an eye problem already, that could be made so much worse, exacerbated by this entire situation that we've unfortunately had to learn to live with. But like all things, we have to work out how to make the best of it and how for ourselves to improve our own quality of life, how to exercise even if you're sitting on your couch. There's simple exercises that Claudette is always happy to share. They eat the correct foods and just try and be in touch with people, even if it's on your phone or if you shout to your neighbor or something like that, so that you're not completely isolated. And I would say that for me, certainly not having the vaccination would be a lot more stressful than having it, because if I didn't have it, I would be living every day with the fear that I could be exposed.
Absolutely. And I think that you are always such a sane voice in this mad world, and we really appreciate you sharing your tremendous knowledge and expertise with us. And if there are no further questions, we're going to close because we're almost out of time. But I would like to close with an appeal to people. If you want to help Retina South Africa create awareness and also to make sure that we bring all these promising treatments and new DNA approaches to South Africa, please support us at absolutely no cost to yourself by nominating Retina South Africa as one of your beneficiaries on www.myschool.co.za. And every time you shop at Woolies or any one of those stores, we will get a certain percentage of your shop, not from you, but from the organizers. So please help us to create awareness and to spread the good news that your future, your life, and your vision is certainly in your hands. Thank you very much, Karen.
Thank you.
And we hand over to Alta.
Thank you.
Thank you so much, everyone. That was really wonderful, as usual, Karen, in the way you do it in such a way that we can all understand, and the way the two of you are able to answer every question that we have. Thank you so much. It was a most enlightening discussion. We really appreciate it.
Thank you very much, everyone, and thank you to all the attendees.
Thank you.